Welcome to Metabolism and Transport. This is actually something that I teach in toxicology. So several of you may have already seen some of this. This is a little bit longer in terms of slide number, but first of all, because a lot of you have not taken toxicology, I still need to go through it. There's biotransformation or metabolism. And secondly, I want to say I'm going to move pretty quickly because a lot of it is a lot of detail that I think you should be exposed to once, but not a lot of it should be committed to memory. And I'll clarify which parts should and should not be committed to memory. So this introductory slide is actually one of the more important slides, although it looks like a cartoon. It's important because it's a really, I think, a concise summary of metabolism and the purpose of metabolism. So what I have in the bottom left there is a capsule. The capsule is going to first, just pretend it's a drug molecule, but just to represent the drug, I have a capsule there. But a drug molecule goes through phase one, in many cases first. It doesn't have to. Phase one metabolism is called functionalization. It's very simple. The meaning just means that you're adding a functional group. It could be a hydroxyl group, it could be maybe an amine, maybe a carboxylic acid. So functionalization is functionalizing. Okay, so I'm making the analogy that it's maybe a child, and for the child that it's going to go swimming, they're going to put on those floaty things, whatever you call them, on their arms. So they're going to first, this is obviously just artificial, but I'm putting on arms first, saying that the arms are the functional groups. That would be like the hydroxyl group. They need those arms or functional groups in order to be basically putting on those floaters, which would help them swim. The reason why this is an accurate analogy is because phase two is generally considered to increase water solubility of drugs. Okay, so phase two is generally much bigger chemicals being added, right, added to your phase one metabolite. So that would be called conjugation. So you're actually adding or conjugating. That would be things like glutathione, glucoronide, sulfate, which is not so big, acetyl, methyl groups, and just a couple of other ones. Now, there are exceptions. Obviously, methylation is not necessarily going to increase water solubility, but the majority of these conjugation reactions do increase water solubility, and this is to help you remember that. So now it's ready to swim. Okay, and actually, out of kind of tradition, I put Dr. Witzak down there because he used to teach this, and he used to love calling the drugs good swimmers, and we're trying to make good swimmers to get them out of the body so they could be renally eliminated or hepatically eliminated better. So just to summarize, biotransformation typically increases water solubility. That's the same as saying metabolism. Biotransformation and metabolism, pretty much the same thing. These enzymes are very promiscuous, and what I mean by that is they metabolize diverse substances. Okay, so the enzymes were not designed to metabolize drugs. They evolved well before medications were invented, right? So the enzymes have evolved to break down toxins and other things, and even metabolize some endogenous compounds like your sex steroids and things like that. So they evolved a long time ago, and now the drugs are similar enough to some of these compounds that they will also be affected or chemically modified. So the metabolic enzymes are highly polymorphic, and I wanted to bring that up right now because throughout pharmacotherapy, you should see that, particularly in certain diseases, there are a lot of drugs that are susceptible to this. So genetic polymorphisms, that means cytochrome P450, 2D6, 3A4. Those enzymes are so different in so many different people that the response to drugs are very different. And that's why you may have a family member ask you, now you're in pharmacy school, so maybe you can tell me why does people respond differently to the same dose, to the same drug, and the same weight of the patient. And it's usually because of genetics. So that's the fourth bullet as well. And finally, the relevance of stereochemistry. This is actually more practical than you would think because certain enantiomers are metabolized more rapidly than the other ones. So when a drug is given as a racemic mixture, it may have a different metabolic activity or metabolic destruction or modification than if the drug were just given as an enantiomer. So you see when the drugs are repatented as enantiomers, you can't assume that it's going to function the exact same in terms of its pharmacokinetics, because maybe that one enantiomer is metabolized slower or faster. So again, this is just bringing up more kind of formally, like the phases. There's phase 1 and phase 2. Those are the major phases. There's a phase 3, but that's kind of a minor point here, so I'm not going to bring that up. But phase 1 is called functionalization. As I said, that's hydrolysis, reduction, or oxidation. The huge one is oxidation, because that's your cytochrome P450 system. I really want you to commit that to memory, that cytochrome P450, all those enzymes, their major function is to oxidize chemicals. Okay, so usually adding an oxygen, actually. So phase 2 is conjugation. These are some of the most important reactions in your body. For example, glutathionylation is when you're adding glutathione. That is one of the most important conjugation reactions in the body. That glutathione detoxifies a lot of oxidative or drugs that have oxidative stress, that are having free radicals and things like that. Glutathione just by chance happens to be what we're boosting when we give the antidote for acetaminophen, that N-acetylcysteine, that produces glutathione, so we can further counteract the toxin from acetaminophen. So a lot of these are very important for getting drugs out of the body. And a lot of these are also polymorphic. Acetylation is a major polymorphic, a global polymorphic enzyme. The acetyltransferase is different from different nationalities or genetics. Again, some just basic overview stuff. Where are the enzymes on an organ level? The enzymes are mostly in the liver and the GI tract. Yes, your intestines do metabolize drugs. Mostly, though, your liver is the big factor there. Now, the kidney, skin, lung, nasal mucosa, eye, and blood, those all have different metabolic enzymes. Some of them are overlapping with the liver, but some of them are unique. Okay, so I just don't want anyone to assume that the liver is the only thing that's doing this activity. Okay, it's just a little bit more extensive than the others. This is FYI, but you might be interested. Where are the enzymes in the cell that are doing this activity? And that would be mostly the endoplasmic reticulum and the cytosol. So these are just some examples. So phase 1 metabolism, I said there's hydrolysis, reduction, and oxidation. These are not super common. There's carboxylesterases, cholinesterases, and peroxygenases. Okay, they're mostly bloodborne enzymes. That means they're circulating through the blood. And xenobiotics obviously are foreign compounds. The esters and amides are hydrolyzed by 2 carboxylesterases in humans. That's human carboxylesterase 1 and 2. Okay, cholinesterases are important for metabolizing organophosphate insecticides. Okay, so this, again, I took some of this from toxicology, but still relevant. So cholinesterases break down things that resemble acetylcholine for the most part. Okay, hydrolysis. Again, there's more on hydrolysis. Epoxide hydrolases add water to alkene epoxides and arene oxides and are present in most tissues. Okay, I'm going to skip through this because I don't want you to commit this to memory. You're not going to see a lot on this. Okay. Yeah, you're just not going to see a lot on this in terms of the medications that you're going to learn about. Reduction, functional groups susceptible to reduction include aldehydes, ketones, disulfide, sulfoxides. The following agents are used endogenously along with enzymes. So reduced glutathione, again, that's a very important detoxifying substance. That can be used, like I said, you could conjugate drugs with glutathione, or glutathione could actually be used to reduce drugs, which can hopefully detoxify or facilitate their removal from the body. And then FADH and NADPH. And those, for the most part, this is FYI for this slide. Okay, these are some pretty detailed examples, but of the different types of reduction. And I don't want to go through each one at a time here. But many different functional groups can be reduced. Okay, so if you're interested, I encourage you to look at a few of these. But again, it's not something you're going to be able to memorize until you see them applied in practice, when we talk about them in pharmacotherapy. So these are some of the things, but just remember reduction typically means adding a hydrogen to something, right? So further reducing that. Oxidation is the big one here. Like I said, we're going to start off with some that are not cytochrome P450, and then we'll get into cytochrome P450. The ones that are interesting to me are the alcohol dehydrogenases and aldehyde dehydrogenases because those actually metabolize ethanol, and almost all alcohols really, like the simple alcohols, follow the same pathway. They go through alcohol dehydrogenase and aldehyde dehydrogenase, and they usually produce the first metabolite would be typically an aldehyde, and the second metabolite would be an acid. So ethanol would be acetaldehyde and then acetic acid. Methanol would be formaldehyde and then formic acid. There aren't many drugs that are going to follow these pathways, so I don't want to spend a lot of time on them. Okay, so I'm going to move on. And this I stole from toxicology, but I don't want to spend a ton of time on it. But just FYI here, ethanol is metabolized by several different enzymes, but the one we're focusing on right now is the alcohol dehydrogenase, which produces acetaldehyde and then acetic acid. This is highly polymorphic, this aldehyde dehydrogenase 2, and that's why some people that drink beer can't handle it, or alcohol, because they can't metabolize the aldehyde and they get very red, maybe a headache, maybe nausea. In certain parts of the world, that's more common. Next is peroxidase-dependent co-oxidation. Okay, believe it or not, so you may or may not have heard of cyclooxygenases, which are the target of NSAID drugs like indomethacin, naproxen, ibuprofen. But these cyclooxygenases are also called prostaglandinase synthases. What happens is basically they remove oxygen from a substrate and then transfer it to a xenobiotic. Okay, so even though, again, this is a different idea. Again, these enzymes are targeted by NSAIDs, but the enzymes themselves can produce metabolites. Okay, so for instance, phenols and amines could be metabolized. Okay, and then the free radicals that are produced from these cyclooxygenases can be damaging in some cases. So this is the point. Again, the target of the NSAIDs would be different cyclooxygenases. That's going to convert arachidonic acid into a prostaglandin. The main point, though, is as the prostaglandins are produced, there's a side reaction that can, with some here, this is a xenobiotic, some compounds or some drugs, they could be, oxidized, or we can produce a free radical there, and that could be detrimental in some cases. So now on to the more important point, I think, because you're going to hear about it a lot more later on, is cytochrome P450. Actually, one pharmacist asked me when I was an intern what cytochrome P450 meant, because she didn't know, and I didn't really know at all at the time. And I looked it up, and it's a lot simpler than than you might expect. It just basically, cytochrome P450 stands for cyto meaning cell and chrome meaning color. And when this enzyme system is extracted from a cell, it can produce a very high absorbance peak at 450 nanometers. That's the blue light. So it absorbs a lot of blue light. And that's why it's called that. So 450 nanometers of light is its maximum absorbance in a spectrophotometer, and that's all it is. It's called the Sorey peak or Sorey band. Okay, so that's the only reason why it's called that. So CYP450 metabolizes an overwhelming array of biotics. Okay, the highest abundance is in the endoplasmic reticulum, but you will find, again, that's subcellular, but you will find cytochrome P450 in most tissues, just more abundant in the liver, some in the intestines, the small intestine, and then scattered throughout the body, and probably a lower amount. Okay. Cytochromes they're heme-containing proteins. So just like hemoglobin, these require that porphyrin ring called heme, and that is what's binding to the oxygen. So you might not have realized that these enzymes are actually related in a sense to hemoglobin, because they use the same structure to bind oxygen, and that oxygen is required for the oxidative reaction. Electrons from NADPH are transferred to cytochrome P450 through the protein NADPH cytochrome P450 reductase. That's FYI. But this the enzymes themselves, which are the cytochrome P450s, like again 2D6, 3A4, and the reductase, are embedded in the endoplasmic reticulum membrane, and then they work together very rapidly. Some of the major oxidation reactions, again, I'll just reiterate one more time, it's an oxidative enzyme system, so it doesn't do everything, right? It just mostly does oxidation. So hydroxylation of aliphatic or aromatic carbon, that's one reaction. Epoxidation of a double bond. You remember epoxide is a 3-membered carbon ring. Heteroatom oxygenation and hydroxylation, that's nitrogen hydroxylation. Heteroatom dealkylation, removing carbons. Oxidative group transfer, cleavage of esters, and dehydrogenation. So these are just some examples here. Okay, I might have used some from toxicology, and some are actually drugs here as well. So let's see, tolbutamide, that's probably an old drug, but that is converted to for example, we're losing, or actually we're gaining a hydroxyl group, sorry, on this methyl. We're gaining a hydroxyl group by CYP2C9. Lauric acid is not a drug, but you might be familiar with that. Remember, sodium lauryl sulfate is in shampoos and things, so this is related to that. That can be hydroxylated as well. Testosterone is obviously endogenous, or it could be given as a gel and things like that for low testosterone. That is hydroxylated as well by 3A4. Coumarin, which is related to Coumadin, it's slightly different from the drug Coumadin, but this Coumarin is more natural, that produces hydroxycoumadin or coumarin by CYP2A6. Okay, so those are just, please don't memorize the drugs here, but just understand that this is one of the reactions of cytochrome P450. That's the main point here, because this is the introduction to the metabolism. And you'll get metabolism in most PT modules later on. So just remember that. Hydroxylation is one reaction of cytochrome P450. So what does that mean? You should be able to at least recognize that. Okay, cytochrome P450, oxygenation and epoxidation. Okay, so Prilosec or omeprazole is the sulfoxide is converted into the sulfone. Okay, that's a little confusing, but you're adding the oxygen. Okay, lansoprazole, which is Prevacid, that is also, you're adding an extra oxygen to the sulfur group, and that's considered a sulfone. Okay, those are just a couple examples. These are these are actually older medications, but we won't get into those. Let's see if there's anything else we could look at. Verlucast is a drug as well that is converted to an epoxide. I'm sorry, I said 3 carbons, but it's a 2 carbon in an oxygen chain. That's the epoxide there. Okay. So earlier I said that was again 3 carbons, but it's obviously the oxygen. So that's the oxidation reaction. So you're making actually you're really modifying this in a large way, removing a lot. Okay, but then actually right here on this part of the structure and this double bond, you're producing the epoxide. So that's just one example, okay, of epoxidation. Actually, all these epoxidation, epoxidation, epoxidation. So please remember that these are reactions of, again, CYP450. So next, for cytochrome P450 would be dealkylation and oxidative group transfer. So on the left here, we have dealkylation, and that just means removing some carbons, right? So it's pretty simple. We have C2H5 being converted into hydroxyl group. So what I want you to do is stop for a second and think with me about what I said in the beginning, functionalization. So I want you to think, through the examples I'm giving now, do you consider these functionalization reactions? And I hope that for the most part that you do. You're adding certain functional groups, or either adding them or exposing them, and the main purpose is to allow the conjugation reactions to occur later on, which will be the next phase. So we're going from this alkyl group on here, so that's an ethyl, let's see, that's actually an ether there, and then you're converting it to just a hydroxyl group. Okay, dextromethorphan, which is a cough suppressant, removing the methyl group, converting it to a hydroxyl group, et cetera, et cetera. Mercaptopurine is an anti-cancer drug, and then this is not a drug at all, but it's a silica-based substance. So we'll not get into that. Diazepam, of course, is a sedative. Okay, might be used for muscle relaxing as well. You can dealkylate here and produce the protonated amine there, or you're adding this this hydrogen to the amine and getting rid of the alkyl group or the methyl group. Caffeine, by the way, this is FYI, but I always found it interesting. Caffeine is metabolized into theobromine, which is the main stimulant in tea. And theophylline is an older drug that can be used for to help with breathing. It used to be used a lot more for asthma, but there are better drugs now. But that's also metabolite of caffeine, and these are all being dealkylated. So you can see right here, here, and here. So the body is one of the most complicated chemists that you could possibly find. And a lot of these things are a lot harder to reproduce, in the lab without an enzyme. Okay, so a lot of specific reactions here. Amphetamine is deaminated. Okay, this is considered an oxidative group transfer. But again, amphetamine is deaminated. We have an oxygen here in place of that amine. Oxidative desulfuration, we're taking parathine, which is actually a pesticide, so it's not a drug, but that is converted to the oxygen. We're adding to that. Okay, so that's, what would you call that? A phosphoester, basically. Actually, it's like a dual phosphoester. Thiopental, which is the old truth serum drug that used to be used to get maybe during wartime to get soldiers to like that were held captive, to get them to reveal secrets and things because it affected their state of mind, to allow them to be uninhibited. So that would be again an oxygen as well. So next is ester cleavage. The easy example and more practical would be Claritin or loratadine. That is converted to the just the amine form. We're losing this whole ester. Remember, an ester is C double bond OO, COOR actually. So it's got to have another carbon. Otherwise, it would be a carboxylic acid. So this ester is removed, and then we have desloratadine, which is also a drug, right? So it's interesting. We get a lot of these medications are just the metabolites that could be administered as the drug or as the parent compound there. So it's kind of interesting. Next is dehydrogenation. Too many examples to go through. Let's look at some actual drugs that we know of. Acetaminophen, remove this hydrogen here. Nifedipine, which is used for blood pressure, things like that. Coronary artery disease for vasodilation effects. We're simply removing that hydrogen there. Nicotine, valproic acid, et cetera, et cetera. And then some endogenous things like testosterone. So I want to just remind you one more time that a lot of our endogenous steroids use the same enzyme systems that drugs use. There's potential for interactions there sometimes, competition with the drug substrates. So that's, I won't ask you that on the test, but I just think it's something interesting to remember for the future. So with all this detail here, I guess you're wondering what would I possibly want to ask you? I'd like to keep it really basic. So what are the main reactions, right? What are the main reactions of cytochrome P450? So be able to name them to be able to recognize at least one. So if I give you one of these examples, just look at the functional groups. See nifedipine going to dehydronifedipine. I won't ask you to tell me the name, but I'll say, well, what type of reaction is this? And obviously it's dehydrogenation. I'll try to keep it as simple as possible and as clear as possible. So acetaminophen, you're losing a hydrogen, so that's dehydrogenation as well. So just a little bit on the variability of cytochrome activity, because this is so important in patients. Some CYPs are functionally similar, or that's considered conserved among different mammals. CYP 1A1, 1A2, 1B1, 2E1. And this is just kind of, if anyone's ever interested in veterinary medicine, and then I'll move on to the clinical stuff, but other CYPs exhibit variable function or regulation between different species. So for instance, dogs and cats, totally unrelated metabolic routes. They have so many differences in their metabolic activity. So using, for example, beagles that they would use from time to time in a drug company to look at the metabolism of a drug is not a very useful method because their metabolic enzymes are so different from humans. Okay, so the main point is to never assume that if you're working with an animal or treating an animal that the metabolism of drugs is the same as humans. Okay, so now getting on to the third bullet, activity of CYPs is variable between different humans. We talked about that. That's basically generally that's polymorphisms. Okay, for the most part, it could be other reasons, but it's usually a genetic difference. Activity, and this is just as important, activity can also vary over time in a single patient as a function of age, diet, exposure to drug and non-drug xenobiotics, and disease states. What I mean by that is if you're treating a patient with a drug, whatever drug that's metabolized by CYP450, as they age, that function can change, right? As they get elderly, or if they're pediatric and then they become an adult, that could change drastically. So the metabolic activity will be very different. Their diet can induce or inhibit enzymes like grapefruit, like I said earlier. One of the most important factors is previous exposure to drugs. So as you give certain medications over time, they can inhibit or induce enzymes. So if you start to induce an enzyme, the drug will be metabolized more rapidly, which eventually that means that the drug may be less effective over time because of enzyme induction, or that just means increase in enzyme activity over time. So all these things can change your metabolic activity over time, and disease states. Obviously, liver failure and things like that have a major impact, right? Because you won't be able to metabolize any drug that's metabolized by the liver, right? It'll be very poor in that case. So all these are really important. So please keep that in mind. So and this is actually, I should have probably moved to this earlier, but this is the diagram of all the different factors. Okay, and I already talked about all of it. Okay, so it might help you to look at it this way rather than just looking at the text. But what can happen to change CYP activity? So diseases, drugs, age, genetics, diet. And again, xenobiotics, drugs are xenobiotics, toxins are xenobiotics, anything that's foreign to the body, right? Xenobiotic. Now these are just for, to give you examples, there's too much to memorize, but these are clinically relevant CYP450 substrates, inhibitors, and inducers. The substrates, meaning that means they are metabolized by these enzymes, so 1A2, 2A6, etc. These are metabolized. But please understand a substrate is going to essentially be an inhibitor too, because the substrate is going to occupy binding sites. It's going to compete. So if you have two different substrates, they're going to compete with each other and slow each other's metabolism down. Inhibitors you can have inhibitors that are not substrates, which is not super common actually, although it looks like it here. And what I imagine is a lot of these that are listed as inhibitors might be both inhibitors and substrates. So you don't really need, for my purposes, like you don't need to know these names, but also just understand that a substrate is going to be an inhibitor as well because it's competing. Inducer is a whole other game. You could have a substrate that's an inducer. So these are not as common, but I know later on in the curriculum you'll be asked to memorize some of these, so I won't have you do that now. But one of the big ones is like phenobarbital, rifampin. They're very, very good inducers. Not only do they induce their own metabolism, but that means any other substrate that uses the same enzyme that's being induced, that will have enhanced metabolism, which could be a bad thing if it's changing efficacy or toxicity. This is just continuation of that list. 3A4 is brought up so often because just look at all the drugs and even some foods like grapefruit juice and other non-drug things that are metabolized by CYP450, 3A4, and then 2D6. 2D6 is one of the most genetically diverse, tons of polymorphisms that affect Mostly central nervous system drugs, antipsychotics, anti-anxiety drugs, antidepressants. For some reason, those are really, really good CYP2D6 substrates. So people have very different effects depending on their genetics for that enzyme. I'm going to skip past this. I stole this from my tox lecture. These are actual drugs and non-drug substances that they're made toxic, right? They're actually converted to toxic metabolite by CYP450. Okay, obviously Tylenol is one of the big ones that we need to know about. Acetaminophen is converted into something called NAPKI, which is very toxic, and we have to detoxify that. If we overdose, particularly, we'll have to give the antidote, of course. And then some other ones that you might find interesting. Some of them are completely unrelated to drugs, like styrene, which is in polystyrene. Before polystyrene is produced, I mean, if you have just pure styrene liquid before it's polymerized, that is going to be a toxin that's activated by one of your major enzymes, 2E1. Right? So just please understand these enzymes are not all heroes, right? The enzymes are not thinking. They're not saying, well, I better protect this patient. I better protect the person that I'm in. No, the enzymes are just finding something that resembles their normal substrate, and they're messing with it. So they don't know, they can't know. They don't have brains, right? So they produce toxins. They produce sometimes inactive metabolites. They just produce a lot of different things, and the pharmacist needs to be aware which of those are relevant to the patient. Phase 2, just remind you, that's conjugation. So we need to swim better. That's the main function of phase 2, is to, again, make them more water soluble, the metabolites, that is. Okay, so the major conjugation reactions, I'd like you to be familiar with the names, will be glucoronidation, sulfation, acetylation, methylation, glutathionylation, and then conjugation with amino acids. You also need to be familiar with the fact that for conjugation to occur, there are 3 major factors or ingredients to the recipe, if you will. There, enzyme. You need an enzyme for conjugation. You need a co-substrate. This is a little bit different from phase 1. The co-substrate would be a larger molecule that you are conjugating your drug with. That would be, for example, glutathione. And then you need the actual drug, which is a xenobiotic that has an appropriate functional group. And this is where I want to stop and say that you could administer a drug that already has the appropriate functional group. So remember, phase one doesn't absolutely have to happen. If you give a drug that's already possessing a hydroxyl group, it may go right to phase 2, right? You can bypass phase 1. So again, these enzymes are not talking to each other saying, now it's your turn. They're saying, what is in front of me, and does it fit into my binding pocket? So they don't really care where it came from, right? So if you give it, it's already prepared to be conjugated, then it'll be conjugated. Some things won't be conjugated until they're functionalized with phase 1. So conjugation, again, boosts water solubility, except these 2 exceptions here, methylation and acetylation. Most conjugation enzymes are in the cytosol, and that's FYI for me. So we're going to break them down into the individual reactions. First is glucoronidation. That's addition of a glucuronide group. The main enzyme there would be UDP glucuronyl transferase, which is for short is UGT. I could think of UGT1A1 as being one of the pretty common ones that is polymorphic, actually. They use a co-substrate called uridine diphosphate glucuronic acid. And the major targets are alcohols, carboxylic acids, amines, and sulfhydryls. Okay. I want you to understand, because there's a lot of detail here, but one of the things I really want you to understand is that glucuronides are excreted in bile or urine. In that, as soon as these drugs are glucoronidated, they have generally a much higher affinity for transporters in the kidney and the liver that pump them into the urine and the bile. Okay, and that's what's on that third from the last bullet there. Okay, and I'm not going to go through the rest of the bullets. I think those are the pertinent ones. And this is what it looks like. Glucoronic acid on the right there, that is basically, it's stolen from this kind of a co-substrate, this UDPGA, and because you could see that the right the prefix there's gluc, that means it's like sugar related, so it is a sugar that's cleaved off of this precursor and then added to drugs like morphine, propofol, aniline, not really a drug, but that's an industrial product. But propofol is actually the drug that Michael Jackson is thought to have died from overdosing on, and that is metabolized by UGT1A9. So there are many different forms or isoforms of this enzyme, the UGT. Okay, so that's just an example. So please remember, conjugation means you're taking the parent drug and then or the phase 1 metabolized drug and then adding something pretty big. So this glucuronide group, is a pretty significant addition to that molecule. Sulfation is adding a sulfonate group, SO3, not SO4. Okay, I'm not going to ask you that detail though. It does need a co-substrate called phosphoadenosine 5-phosphosulfate, or PAPS, that is catalyzed by sulfotransferases. Okay, this is again the co-substrate. This large molecule is just donating this sulfate, okay, or sulfonate, and that is going to sulfate a lot of these different things here. Acetylation is simply addition of an acetyl or acetyl group. N-acetylation is very common, and the substrate acetyl-CoA. You probably thought you were done talking about acetyl-CoA from biology, but it's used as a co-substrate here. And the enzyme that does this is N-acetyltransferases. Those are also polymorphic in humans. So slow acetylators, that means people that don't have much activity here, are susceptible to toxicity from drugs like hydralazine, isoniazid, and procainamide. And a lot of those can cause things like hemolytic anemia due to slow acetylation or slow detox of the drugs. Now this is that one of the exceptions, right, where it causes an increase in lipophilicity. Okay, and the last bullet is going to be FYI. This is not something to commit to memory, but I wanted you to be aware, not of the numbers, but the fact that you should know that there are differences in different populations. There are different proportions of slow acetylators and fast acetylators. So people that are from India have about 60% of that population would be slow acetylators. If you happen to be Korean, you have a 90% chance of being a fast acetylator or 10% slow acetylator. That means generally you metabolize drugs that are acetylated, you metabolize them faster, you can eliminate them probably faster. That's usually a good thing if you're talking about detoxifying. That's a bad thing though if you want prolonged efficacy and the drug is being removed too fast, right? You don't want to remove it too fast in some cases. So it all depends. So we're not going to get into that detail, like which drugs am I talking about, but just understand that it depends on, is the drug active when you give it, or is it active as the metabolite? And are we dealing with mostly a concern of efficacy or mostly concern of toxicity? And that will determine the relevance or how important is acetylation status. So one example here of a drug would be sulfamethoxazole, which is in Bactrim, right? Sulfamethoxazole and trimethoprim. That amine there could be, we could add the sulfate to that amine. I'm sorry, acetyl, not sulfate. The acetyl group to that amine right there. Okay. This dapsone sulfamethazine isoniazid. Isoniazid is an actual drug that's used. Sulfamethoxazole is used. Dapsone is not that common. Sulfamethazine, I'm not sure. So some of these are actual commonly used drugs. Some of them are not. Okay, and this is the actual acetyl-CoA. In this massive molecule, we're just taking this acetyl from it. So it's a very large structure, which we're taking just a piece from. And so again, this is one more reminder that we need the co-substrate, the enzyme and the drug. 3 components for this reaction to work. Next is methylation. I'm not going to spend a lot of time on it. It's a minor pathway for drugs. This is another exception where the methylated drugs generally have a higher lipid solubility or lipophilicity, so it breaks that rule of making them better swimmers. Okay, and these are some examples of methylation. As you can imagine, you're just adding a CH3. L-dopa is a drug that's methylated. Nicotine, histamine is obviously endogenous. So I'll move on to the next one. Glutathionylation to me is one of the most important reactions because particularly because I teach toxicology, I know that that is one of the most important detoxifying peptides, right? It's a peptide that has 3 amino acids. It's glycine, cysteine, and glutamate. It's very concentrated in the liver in some cases. And again, when you give drugs like, antidotes like N-acetylcysteine, you can bolster that, right? You can produce glutathione from that. So that's why it's useful as an antidote, because it boosts this detoxifying activity, which is an antioxidant. Okay, so the enzyme that's required is glutathionase transferase. The actual enzyme itself can make up to 10% of cellular protein, which is gigantic because of, think of the thousands or I don't know, hundreds of thousands of proteins you might have. Sometimes liver cells might have 10% of their protein being just this enzyme. Okay, so critical for detoxifying, especially drugs that cause oxidative stress. Okay, and that bind to DNA and protein. So this is actual glutathione. Again, it's a tripeptide, so it's one of the strange, kind of a strange conjugation reaction because it's one of the few that's actually using like this mini protein here. Again, it's glutamate, cysteine, and glycine. And so maybe that hopefully would make sense to you that when you add as an antidote for acetaminophen, you add N-acetylcysteine, you give that to a patient, you can, basically reduce this to make sure it's in the SH form. That SH form is called reduced glutathione, and that is your protective glutathione. As it bears that proton, that can go around and detoxify other things. Okay, that can detoxify other things, or the whole thing could also be conjugated with other substances. So these are some of the things that can happen. The glutathione could directly replace halogens, nitrates. Okay, it can, let's see, work on some other compounds that we don't get into in too much detail. So these are all examples of glutathione conjugation, right? It's actually being added, and that's what we're talking about in this lecture. You're actually adding the glutathione. But remember I said that also just having that reduced glutathione, GSH, sometimes that could just donate a proton as well. Without conjugating, you could still donate a proton and detoxify certain things as well. So finally, for the last slide on conjugation, I wanted to show you a series of events that can happen with, again, a glutathione conjugate. So we start off with a substrate, so this will be a drug. So Rx, we'll just say, this entire structure here is the glutathione. The glutathione can be added to the drug, and this is showing you that you removed this, whatever this X group was has been removed, and now we just have the R group, which is the drug, and then this entire glutathione. What happens in many cases, of course that happens in the liver in many cases, but then what happens in sometimes in other tissues is you'll lose pieces. So in this case you would lose the glutamic acid in the kidney. Then the kidney would also cleave off the glycine, and you're left with something called just a cysteine conjugate, and that can basically then be modified with an N-acetyltransferase to the mercapturic acid and then being excreted in the urine. That's a lot of detail there. And what I'm trying to get at is that just because something is conjugated with glutathione or anything really doesn't mean that's the end of its metabolism. In this case, the kidney will recognize that glutathione conjugate and then modify it to help eliminate it. Okay, so I guess the moral of the story is metabolism is way too complicated to try to memorize every portion of it. And just because we've identified some metabolites doesn't mean that, right, that's the 100% of the picture, that there's nothing else happening in the body. It's very complicated. So one drug might result in 10 to 20 metabolites, for example, and then maybe really minor ones that you don't typically see when you're studying them. So lastly, I want to talk about excretion, which is a focus on transporters, because we talk a lot about excretion and clearance in this course. Okay, but I want to talk just about the transporters involved in excretion, and very briefly, because this can get into a lot of detail, but I won't do that. So drugs and toxins can be removed from the body by several routes: hepatic, which is fecal; renal, which is urinary; pulmonary, which is exhalation; and then minor routes, there's sweat, saliva, tears, and breast milk. The route of excretion depends on the primary organs into which the toxicant diffuses or is transported, and it depends on the water solubility of the chemical and its metabolites. The kidney is, of course, a major excretory organ. Toxicants in the metabolites may just simply get filtered through the glomerulus, or they may be transported, or both. Okay, and please remember what transport means. That means that if something is not filtered at the glomerulus, it will continue in the bloodstream, which is called the vasa recta, and then it'll be parallel to the tubule, and sometimes that blood flow next to the tubule will have, again, the drug in it, and the drug will get transported from the blood into the lumen of the tubule. So a lot of factors influence the likelihood of renal excretion, and I'm saying toxicant because I took this from the lecture, but it's also a drug, the same thing. Renal blood flow is directly proportional to renal elimination rate. Okay, plasma protein binding is directly related to filtration. The more plasma protein binding, the less filtration, and vice versa. The more secretory transport, the more excretion. Okay, the more reabsorptive transport, the less excretion. So if something's highly secreted, that means it's highly pumped into the urine. Okay, and that's a good thing for elimination at least. Generally, lipophilic compounds are more readily reabsorbed back into the blood, and that's why people say that the kidney likes water-soluble things for elimination. Typically, it doesn't mean lipid-soluble things don't get out that way, but typically they're reabsorbed in many cases. So this is just to reiterate what can happen and what are the factors here. Plasma protein binding is going to determine how much filtration we get, right? So if something's 99% bound, 99% of it won't even have a chance to get filtered here. It'll keep going, and then remember, this will come back around. Eventually, it'll come back around next to the tubule, right? It's not shown here, but the blood vessel, the efferent arteriole, will come back to the tubule, and then you have another opportunity to basically, with these capillaries that are coming, another opportunity to have the drug get into the lumen through secretion. So remember, secretion is moving into the urine, reabsorption is moving out of the urine. So if we want to get rid of something, we want more secretion, less reabsorption. That's how we get it out of the body. And combine that with filtration, we have these two major routes to get something into the urine. Again, that's filtration and secretion. I'm not going to spend time on this slide because I'm going to show you the diagram of the major transporters. Okay, these are just some of the major ones that have been identified starting in the mid to late 90s. Secretory transporters in the kidney would be 1, 3, oct 1, 2. These are anion transporters up top, cation transporters, and then some others. Then the efflux transporters, which are pumping drugs, they're still involved in secretion, but instead of these ones that are basolateral, the efflux transporters are on the apical membrane. They pump drugs right into the glomerular filtrate. And then the reabsorptive transporters are on the right here. That means they promote drugs being reabsorbed back into the blood. So you have kind of a dynamic, right, a competition between reabsorptive and secretory transporters, and whichever ones end up dominating, right, that's going to determine does more drug leave the blood or enter the blood, or leave the urine or enter the urine, based on this kind of dynamic between reabsorptive and secretory transporters. Obviously, in real life, they're not separated on different cells. All these transporters would be together on a cell, right? And they're in this diagram, they're just dividing them to make it a little bit easier to see what's going on. And then in the liver, we have the same idea. We have transporters that would take drugs from the sinusoids, pump them right into the liver cell or hepatocyte. We also have transporters that go the opposite way, effluxing right into the blood. And then we have transporters that pump drugs into the bile. I don't want to get into a lot of detail on what drugs because there's so much to talk about, but please understand that a drug may enter the bile more rapidly because it is transported. And if any of these transporters are not functioning correctly, the drug might have impaired elimination.